Welcome, everyone, and thank you so much for joining us today.
Yes, thank you for being here.
If you are a returning listener, or if you are jumping in with us for the very first time, you are stepping right into the heart of the deep dive.
Exactly.
This is where we take a massive, comprehensive stack of source material.
Mm.
I mean, we're talking clinical data sets, medical monographs, user forum archives, and we just break down all those tiny nuances.
Right, because the goal is for you to walk away with a truly thorough, synthesized understanding at the topic.
Exactly. We
And
completely bypass those, surface level summaries. We want to get straight into the complex mechanics of the subject.
no skimming allowed here.
Right. And today, we are directing our focus toward a really highly debated, widely utilized, and honestly, a very regulatory complex medication.
It's a fascinating one.
It really is.
Mhm.
The drug is Vidalista, which is known by its active pharmaceutical ingredient, Tadalafil.
That is correct. And just to ensure we're maintaining absolute precision today, our primary source material is a highly detailed drug monograph. And alongside that, a really rich user forum data set, which was extracted directly from the iMedix medical content engine. Specifically, we are looking at version 3.13.37 today.
Gotta love the specificity of that database.
You do. And the architecture of this specific source is particularly compelling because it doesn't just isolate the pharmacology from the patient.
Right, it doesn't just give us the sterile lab data.
Exactly. It merges that rigid, peer-reviewed clinical data with real-world user interactions and platform dynamics. We are essentially looking at a cross-section of modern digital healthcare information.
Okay, let's unpack this because the sheer density of the information provided in this iMedix database, it really warrants a meticulous approach.
It does. There's a lot to sort through.
Yeah, so we're looking at a PDE5 inhibitor, primarily indicated for erectile dysfunction and benign prostatic hyperplasia, or BPH.
Right.
But what makes this specific deep dive so compelling isn't merely its mechanism of action, or even its really well-documented 36-hour pharmacokinetic window.
No, it's the market positioning.
Yes, it's the paradox of its current market existence. The source material presents a drug that is clearly utilized by a massive demographic. I mean, it is highly rated in user testimonials.
Very highly rated.
Yet it occupies a permanent spot on a quote-unquote not approved gray market generic list.
It's a strange limbo.
It is. So our mission today is to decode the pharmacology of Tadalafil, analyze the real-world application documented in these forums, and navigate the structural complexities of this whole digital pharmacy landscape.
We definitely have a lot of ground to cover, and we need to look really critically at how the clinical realities intersect with actual patient behavior, because the iMedix file gives us an unvarnished look at a medication that exists in a state of regulatory purgatory.
Purgatory is the perfect word for it.
Right, because on one hand, you have the precise half-lives, the strict contraindications, the CYP3A4 metabolic pathways, all the hard science. But then on the other hand, you have individuals just trying to manage their healthcare costs, seeking out high-dose variants that completely lack regulatory oversight, and documenting their experiences online.
It's the Wild West out there.
It really is. I want to examine how the strict boundaries of the medical data hold up against a somewhat chaotic reality of gray market consumer access.
Okay, well, let's establish the foundational identity of the drug first, just so everyone is on the same page.
Good idea.
According to the iMedix data, the active ingredient, Tadalafil, is a phosphodiesterase type 5 inhibitor. It's manufactured in this specific iteration by Centurion Laboratories PVT Ltd.
Correct.
And the FDA-approved indications for this active compound include the treatment of ED in adult men, the management of the signs and symptoms of BPH, and the treatment of patients presenting with the coexistence of both ED and BPH.
And there's also an interesting off-label use mentioned.
Oh yeah, the source notes a specific off-label application for the management of chronic pelvic pain associated with prostatitis.
Yeah.
Though it explicitly states this requires expert physician monitoring.
Right, and the inclusion of that off-label use for chronic pelvic pain is a really interesting detail in the monograph.
How so?
Well, it highlights the systemic smooth muscle relaxing properties of the drug beyond its primary urological indications. It shows the drug is doing a lot more in the body.
That makes sense. But the core issue we need to address right up front is the regulatory status.
Yes, the elephant in the room.
Tadalafil is, of course, the exact same active chemical compound found in the reference-listed drug, Cialis.
The brand name we all know.
Right. And Cialis possesses full FDA approval, extensive clinical validation, the whole 9 yards. Vidalista, however, is explicitly tagged in the iMedix database as not approved. It's categorized as a non-FDA approved generic, and it shares that designation with other gray market formulations they list, like Kamagra, Fildena, and Cialis Black.
It's a really crucial distinction to make.
It is. That regulatory disconnect is a fascinating tension point for anyone studying global pharmaceutical supply chains.
Yeah.
I mean, you're looking at identical active pharmaceutical ingredients, right?
Chemically identical, yes.
Yet they exist in entirely different legal and regulatory stratospheres. The iMedix FAQs actually touch upon the concept of bioequivalence.
Which is the gold standard for generics.
Right. They state that generic versions are required by regulatory authorities to prove they act the same way. They have to deliver the same amount of the active ingredient into the bloodstream over the same duration as the reference-listed drug.
But here's the catch.
Yeah. Despite the requirement for bioequivalence, Vidalista remains on the unapproved list.
I think we need to be really careful here not to conflate unapproved with ineffective or even chemically distinct.
Okay, clarify that for us.
We need to recognize it as a lack of verified supply chain and manufacturing oversight. Establishing bioequivalence for the FDA or the EMA, it's a capital-intensive, highly audited process.
It costs millions of dollars.
Exactly. When a product is manufactured by an entity like Centurion Laboratories and distributed through international online channels, it completely bypasses that domestic regulatory audit.
Ah, so it's a paperwork and audit issue, essentially.
Largely, yes. The not-approved label doesn't necessarily dictate that the molecule behaves differently in vitro. What it dictates is that the regulatory body has simply not been given the opportunity to verify the manufacturing purity, the excipients used, or the stability of the final product.
That is such a crucial distinction, and it really places you, the listener, or any patient navigating this space in a very difficult position.
It's a huge burden on the patient.
Imagine you are managing a condition like ED or BPH, and you are acutely aware of your healthcare costs, which, by the way, the source notes is a highly trending tag among iMedix users.
People are definitely searching for cost relief.
Of course they are. The reference-listed drug carries a massive premium cost, while this generic alternative is readily accessible online at a fraction of the price.
Right.
So the patient is forced to weigh the financial accessibility of the generic against the lack of official regulatory validation. It is a complex risk-benefit analysis that patients are conducting, often without having any background in pharmacology whatsoever.
And that burden of analysis is precisely why a deep understanding of the drug's pharmacokinetic profile is non-negotiable.
You have to know what you're putting in your body.
Absolutely. If a patient is going to utilize a PDE5 inhibitor, particularly one sourced from a gray market channel, they need a robust understanding of its biological persistence.
Which leads us directly to the defining characteristic of tadalafil.
Yes. It's 36-hour clinical duration.
The pharmacokinetics here present a really compelling clinical picture. The iMedix source data details that tadalafil has a plasma half-life of 17.5 hours following a single as-needed dose.
That is a very long time for a drug of this class.
It is. Because of that extended half-life, the clinical effects persist for up to 36 hours. Furthermore, the absorption rate and the extent of absorption are not altered by food intake.
Which is a huge convenience factor for patients.
Right, meaning gastric emptying times or the fat content of whatever you ate for dinner do not impact the drug's bioavailability.
What's fascinating here is how radically that 17.5-hour half-life alters the therapeutic landscape compared to other PDE5 inhibitors.
Like sildenafil, for example.
Exactly. Those typically present with half-lives in the 4 to 5 hour range. When a drug maintains a half-life approaching 8 to 2 hours, it fundamentally shifts the prescribing strategy.
Because it's staying in the system so much longer.
Right. The extended presence in the plasma allows for the two distinct dosing strategies that are outlined in the text. You have the traditional as-needed approach and then the steady-state daily dosing approach.
Let's look at the parameters for both of those because they are very different experiences for the user.
Okay.
For the as-needed strategy, the standard recommended starting dose is 10 milligrams, administered at least 30 minutes prior to anticipated sexual activity. And depending on efficacy and tolerability, that dose can be titrated down to 5 milligrams or up to a maximum of 20 milligrams. The strict clinical parameter here is that administration must not exceed once per day.
The alternative is the once-daily regimen. This utilizes a much lower dose, either 2.5 milligrams or 5 milligrams, and it's administered every 24 hours.
Regardless of sexual activity.
Exactly. This approach leverages that long half-life to achieve a steady-state plasma concentration of the drug. After a few days of consistent dosing, the patient just maintains a therapeutic baseline of PDE5 inhibition.
No more dramatic peaks and troughs.
Right. And the source explicitly notes that for patients managing BPH, or those with coexisting ED and BPH, this daily 5 milligram dose is the standard recommended regimen.
The psychological implications of that steady-state dosing, I mean, they really cannot be overstated.
It's a paradigm shift for the patient.
It really is. Think about it with short-acting PDE5 inhibitors. The patient is required to engage in a highly episodic, reactive form of treatment.
It requires planning.
So much planning. Chronobiological planning, timing the dose, often timing meals, even though we know tadalafil specifically avoids that food interaction issue.
Right.
But by transitioning to a daily 2.5 or 5 milligram dose, the episodic nature of the treatment is completely eliminated. It transitions into a routine maintenance therapy, much like managing hypertension or high cholesterol.
It normalizes it.
Yes, it entirely divorces the administration of the medication from the sexual event itself.
I agree that the steady-state approach offers significant advantages in normalizing the condition, but we must also acknowledge the inherent pharmacological risk of an extended half-life.
There is a flip side.
Always. If an adverse reaction occurs, or if the patient inadvertently introduces a contraindicated substance, that complication is going to persist in the systemic circulation for an extended period.
Because you can't just flush it out quickly.
The drug cannot be rapidly cleared, and this prolonged exposure risk becomes exponentially more dangerous when we start to examine the high-dose formulations detailed in the iMedix database.
Yeah, that brings us to a highly concerning section of the source material regarding these unapproved variants.
It's quite alarming.
As we noted, the maximum established clinical dose for tadalafil is 20 milligrams. That is the ceiling determined by rigorous safety and efficacy trials.
That is the absolute maximum safe limit.
Right. However, the gray market does not adhere to those clinical ceilings. The iMedix database lists available formulations of 40 milligrams, 60 milligrams, and a specific variant branded as Vidalista Black containing 80 milligrams of tadalafil.
80 milligrams is an astonishing dose.
The text is unambiguous regarding the dangers of these formulations. Doses exceeding 20 milligrams are not approved by the FDA or the EMA, and the monograph details exactly why.
It states that supertherapeutic doses are associated with a nonlinear increase in both the incidence and severity of adverse events.
I really want to focus on that phrase you just used, and that the text uses. Nonlinear increase.
It's a vital concept.
It is, because this isn't a simple arithmetic progression. A patient taking 80 milligrams isn't just quadrupling their risk profile compared to a 20 milligram dose.
No, it's much worse than that.
They are pushing their biological systems completely past their saturation points, leading to exponential, unpredictable toxicity.
Exactly.
The specific clinical threats highlighted in the text for these massive doses are profound hypotension and priapism.
And the mechanism driving both of those medical emergencies is systemic vascular overdrive.
Walk us through that overdrive. What is actually happening in the body?
Well, PDE5 inhibitors function by preventing the degradation of cGMP. This enhances the nitric oxide signaling pathway that facilitates vasodilation or the whitening of blood vessels.
Right, which is the intended effect for ED.
But when you introduce 80 milligrams of this compound into the system, you are saturating those pathways far beyond the targeted localized tissue.
It goes everywhere.
Exactly. Profound hypotension occurs because the systemic vascular resistance drops so precipitously that adequate blood flow to your vital organs is compromised.
Your blood pressure just tanks.
It bottoms out. And priapism, similarly, is a failure of the localized vascular system to return to homeostasis. It leads to a compartment syndrome scenario where deoxygenated blood remains trapped,
which poses a severe risk of permanent tissue necrosis.
It is a surgical emergency.
Here's where it gets really interesting when we look at the intersection of consumer behavior and pharmacology.
The psychology behind the purchase?
Yes. The very existence of an 80 milligram Vidalista black pill relies entirely on the psychological fallacy that more is always better.
It's a dangerous assumption.
The standard 20 milligram dose is already engineered to provide maximal receptor saturation for the intended therapeutic effect. So pushing the dose to 80 milligrams doesn't increase efficacy, it only increases toxicity.
You don't get a better result, you just get poisoned.
Exactly. Yet the gray market absolutely thrives on this high-dose branding. They market these pills as premium or extreme versions.
Black implies it's elite or stronger in a desirable way.
The consumer, likely lacking the pharmacological background to understand receptor saturation, assumes the higher number correlates to a superior outcome. They are completely unaware of the nonlinear risk of profound hypotension.
It is a profound failure of health literacy, and it's exacerbated by a marketplace that operates completely outside of regulatory constraints.
They are preying on that lack of knowledge.
The iMedix text appropriately frames these high-strength variants as severe risks that should only be considered under exceptional circumstances with direct medical supervision.
Though even then,
Right. One could argue there is virtually no clinical justification for an 80-milligram dose of tadalafil in this context.
None.
And this systemic vasodilation we are discussing, even at standard doses, is the direct mechanism behind the extensive side effect profile detailed in the monograph.
let's examine that adverse event profile because it perfectly illustrates the systemic nature of the drug. The source categorizes the adverse reactions by frequency.
Starting with the most common.
Right. The common side effects, those occurring in 2% or more of the patient population, include headache, dyspepsia, back pain, myalgia, nasal congestion, flushing, and pain in the extremities.
And each of those common side effects is a direct downstream consequence of the drug's primary mechanism of action.
The vasodilation.
Exactly. When the smooth muscle in the cranial blood vessels relaxes, the resulting vasodilation presents as a headache.
The blood vessels in your head are physically expanding.
Right. And the same localized vasodilation in the dermal capillaries causes flushing. In the nasal mucosa, it leads to congestion.
Oh, that makes so much sense.
The myalgia, which is muscle pain, and the back pain are also sequelae of this altered vascular state. The drug is effectively inducing a transient systemic hypotensive state.
So it's not malfunctioning.
Not at all. It is working exactly as designed, but the receptors are not isolated to the target tissue. It affects the whole body.
Okay, moving down the frequency scale, the less common effects occurring in 1 to 2% of users include dizziness, GERD, visual disturbances, and nausea. But the most critical data points in this section are the serious adverse reactions, where the text mandates seeking immediate medical attention.
These are the red flags.
We have already discussed priapism, but the monograph also highlights sudden hearing loss, which may be accompanied by tinnitus and dizziness and NA-ion, or non-arteritic anterior ischemic optic neuropathy.
NA-ion is a particularly severe complication.
It sounds terrifying. What is it exactly?
It involves ischemia, or restricted blood flow, to the optic nerve head. This results in sudden, often irreversible vision loss in one or both eyes.
Irreversible. Wow.
Yes, the iMedix source explicitly notes that patients presenting with a history of NA-ion in one eye are at an inherently increased risk of developing it in the contralateral eye if they utilize PDE5 inhibitors.
The text is somewhat careful regarding causality, though, isn't it?
It is.
It states that while a definitive causal relationship between tadalafil and NA-ion, or sudden sensorineural hearing loss, has not been absolutely established across the literature, it cannot be ruled out.
The mechanism makes it highly plausible.
Right, so the clinical directive is absolute. Immediate discontinuation of the therapy is required if any sudden auditory or visual disturbances manifest.
And this places a significant cognitive burden on the patient.
Because they have to constantly monitor themselves.
Exactly. They must continuously assess their physiological state, distinguishing between common benign effects like a simple vasodilatory headache and the prodromal symptoms of an ischemic event like NA-ion.
That's a lot to ask of someone just trying to take a pill for ED.
It is. And this risk assessment becomes exponentially more complicated when we introduce the specific demographic warnings outlined in the source material.
Right. Let's look at those demographic stratifications because they are very definitive in the text.
Very clear lines drawn.
Vidalista is categorized as unsafe for women with specific contraindications for pregnancy and breastfeeding, and unsafe for the pediatric population.
No ambiguity there.
None. The guidance regarding the elderly population, however, is much more nuanced. The monograph states the drug is, quote, safe if prescribed for elderly patients, explicitly noting that a dose adjustment is not required based purely on chronological age.
I would argue that safe if prescribed carries a really heavy caveat in clinical practice.
The text itself kind of acknowledges that, right?
It does. It warns that elderly patients may exhibit a heightened sensitivity to the hypotensive effects of the medication. We have to consider the physiological realities of the aging population.
They aren't just older versions of young bodies.
Right. They generally have a higher incidence of comorbidities, altered renal and hepatic clearance rates, and crucially, an increased prevalence of cardiovascular disease.
Which is a huge factor.
A massive factor. The source mandates a thorough cardiovascular evaluation prior to initiating treatment in this demographic, which is entirely appropriate given that the physical exertion of sexual activity combined with a systemic vasodilator places a significant demand on myocardial oxygen consumption.
That cardiovascular vulnerability is actually the perfect transition into the drug interaction data provided by iMedix.
This is where things get truly complicated.
Administering tadalafil as a monotherapy is complex enough, but the introduction of concurrent medications creates a highly volatile clinical scenario.
Absolutely.
The most severe interaction detailed is with nitrates. The text states that concurrent use is strictly contraindicated because the synergistic effect triggers severe, life-threatening hypotension.
The mechanism there is a catastrophic compounding of the nitric oxide pathway amplification.
Break that down for us.
Nitrates act as exogenous nitric oxide donors. They're adding fuel to the fire, while tadalafil prevents the breakdown of the resulting cGMP.
So they're working on the same system from two different angles.
Exactly. The result is uncontrolled, massive vasodilation. This presents a brutal catch-22 for the aging patient population.
Because they often need both.
Right. A patient may rely on nitrates for the management of angina pectoris, yet they also present with BPH or ED. The strict contraindication forces them to choose between managing their cardiovascular ischemia or managing their urological symptoms.
There is no middle ground.
There is no safe pharmacological compromise between those two drug classes.
Similar additive hypotensive effects are noted with alpha blockers and other antihypertensive agents, which, again, are incredibly common prescriptions for this exact demographic.
Almost ubiquitous in older male patients.
The text specifies that if an alpha blocker is required, careful titration is mandatory. You have to initiate the tadalafil at the lowest possible baseline of 2.5 milligrams and monitor orthostatic vitals very closely.
If we connect this to the bigger picture of pharmacokinetics, we have to examine the hepatic metabolism pathways detailed in the source.
Liver processing.
Yes. Tadalafil is primarily metabolized by the cytochrome P450-3A4 isoenzyme, commonly called CYP3A4. This enzymatic pathway represents a significant bottleneck for clearance.
And the source specifically highlights the danger of potent CYP3A4 inhibitors, citing drugs like ketoconazole and ritonavir as primary examples.
This is a critical interaction.
When a patient introduces a potent inhibitor of that specific isoenzyme, they're effectively shutting down the primary mechanism the body uses to clear the tadalafil from the systemic circulation.
Precisely. It results in competitive inhibition at the enzymatic level.
The liver is too busy dealing with the inhibitor to clear the tadalafil.
Exactly. The clearance rate plummets, leading to a dramatic increase in the area under the curve, which is the total systemic exposure to the drug. A standard 10 or 20 milligram dose can rapidly accumulate to toxic levels.
So what does the clinical guidance say to do in that situation?
To mitigate this, the guidance dictates severe dose restrictions. Patients on potent CYP3A4 inhibitors are capped at a maximum of 10 milligrams every 72 hours for as-needed use. Or they are restricted strictly to the 2.5 milligram daily regimen.
The exact same 10 milligram per 72-hour restriction applies to patients presenting with severe renal or hepatic impairment.
Because the filtration systems are compromised.
Right. If the organ systems responsible for clearance are compromised, the half-life extends even further. You need those massive gaps between dosing intervals just to prevent systemic accumulation.
It's all about managing the clearance timeline.
But the interaction that likely has the highest real-world prevalence, the one that people are actually going to encounter, is the interaction with alcohol.
A very common combination, socially.
The text advises to use with caution, noting that concurrent administration may potentiate orthostatic hypotension, presenting clinically as dizziness, tachycardia, and headache.
The alcohol interaction is a perfect example of clinical data colliding with real-world behavior.
Because people drink on dates.
Exactly. Alcohol itself is a central nervous system depressant with its own vasodilatory properties. Combining it with a potent PDE5 inhibitor exacerbates the drop in peripheral vascular resistance.
So you get a double dose of vasodilation.
Right. The sudden tachycardia, the rapid heart rate, is a compensatory mechanism. The heart rate spikes in a desperate attempt to maintain cardiac output in the face of rapidly dropping blood pressure.
It's trying to keep the engine running.
Exactly. So for a patient who has consumed alcohol and then stands up quickly, the sudden venous pooling in their lower extremities can easily result in syncope or fainting. It transforms a really common social scenario into a genuine orthostatic hazard.
And observing how these clinical hazards and therapeutic benefits actually manifest in real-world social scenarios is exactly what the iMedix user forum data provides.
Well, this is a fascinating shift in the text.
It was jarring. The monograph abruptly shifts from this rigid pharmacokinetic data directly to deeply personal user testimonials.
The tonal shift is significant.
We have 5 specific reviews documented from individuals identified as Elena, Bruce, Miles, David, and Ben. And these sit right alongside the corresponding replies from the iMedix editorial team administrator.
The sociological contrast within this section is striking.
It's night and day.
You have patients offering highly subjective, emotional narratives regarding their deeply personal experiences. And that is juxtaposed directly against the sterile, legally calibrated language of the platform administrator.
Let's look at the language the users employ because it's so emotive.
Yeah.
Ben writes, "These pills are just super. I regained my youth in every sense of the word. I got an erection lasting for a few hours. Orgasm, just gorgeous. What is most importantly is that I have not experienced any negative consequences."
A glowing review.
Bruce mirrors this sentiment, stating the medication provides a, quote, natural way and everything ends also naturally. He even notes he couldn't test the maximum duration because the efficacy lasted so long.
Which points back to that 36-hour window.
Right. And then David specifically mentions the social proof aspect, noting he tried it based on a recommendation from a group of friends and that it justified all expectations.
The terminology here is entirely divorced from the clinical reality we just spent so much time dissecting.
They aren't talking about CGMP.
No. They aren't discussing smooth muscle relaxation or steady-state plasma concentrations. They are discussing the psychological restoration of vitality.
Regained my youth.
Exactly. Regain my youth is a profound statement regarding the psychosocial impact of the condition and the perceived efficacy of this generic formulation.
It is intensely emotional.
Yeah.
And then we have Alina's review, which introduces a highly compelling variable into this data set.
This one stood out.
She writes, "This is the best drug of its kind. Acts quickly, erection lasts for a very long time. After orgasm and rest, you can continue to have sex as if nothing had happened. I recommend these pills to everyone."
It's a very enthusiastic endorsement.
But this review is purportedly from a female user regarding a drug explicitly contraindicated for women.
Unsafe for women, according to the text.
Right. So is this a partner reviewing the collateral benefits of the drug on their relationship? If so, it really highlights that the therapeutic target of ED medication extends beyond just the patient to encompass the partner's experience as well.
It's a valid perspective. However, this raises an important question regarding the authenticity and motivation behind digital forum testimonials.
You think it might be fake?
I think we need to approach Alina's review with a degree of analytical skepticism.
Okay, why?
We are examining an independent platform that hosts an advertising disclosure. A review written under a female pseudonym praising the drug unequivocally and explicitly recommending it to everyone bears certain hallmarks of affiliate-driven content.
Ah, like an SEO strategy.
Exactly. Search engine optimization strategy rather than an authentic clinical outcome report. We simply cannot verify the provenance of these reviews, and we must consider the commercial ecosystem in which they are hosted.
That is a very valid critique of the source data. The potential for astroturfing or commercially motivated testimonials in these gray market drug forums is historically very high.
We have to maintain that critical lens.
However, we do have Miles's review, which kind of anchors the forum data back to the clinical monograph we just went through.
Miles's experience aligns much more closely with the data.
Right. Miles writes, "After taking one whole pill, I have experienced small short-term side effects in the form of muscle pain. However, in general, the effect of this medicine intake corresponds to the description."
Miles's testimonial is the practical manifestation of the adverse event profile we analyzed.
The muscle pain.
Yes, the muscle pain, he notes, is the myalgia listed under the common 2% or greater frequency side effects. It provides a brief validation of the clinical data within that highly subjective forum space.
He got the benefit, but paid the vasodilatory tax.
He achieved the intended therapeutic outcome, but concurrently experienced the systemic vasodilatory consequences.
And Regardless of whether the review is a glowing recommendation from Ben or a report of myalgia from Miles, the iMedix editorial team administrator's response remains uniformly rigid.
It is a masterclass in liability mitigation.
Truly. To Ben's passionate report of regaining his youth, the admin replies, "It's wonderful. It's important to note that individual experiences may vary, so it's a good idea to consult with a healthcare professional."
Very copy-paste.
And to Bruce, they reply, "It's great. However, it's essential to use medications responsibly and consult with a healthcare professional."
The pattern is identical for Miles and David as well. The administrator acknowledges the user statement, inserts a disclaimer regarding variable individual responses, and mandates consultation with a healthcare provider.
They are actively constructing a firewall.
A massive firewall between the user's subjective experience and the platform's liability for dispensing medical advice.
It's quite the balancing act.
They are facilitating a community discussion about an unapproved, prescription-only generic while simultaneously demanding the user seek professional medical oversight for it.
Which leads us to the final and perhaps most complex aspect of the iMedix data, the digital pharmacy landscape itself.
The structural context of all this.
The text outlines the basic parameters of access, noting that generic Tadalafil is associated with lower costs than the reference-listed drug, but it maintains its status as a prescription-only medication requiring medical evaluation in most jurisdictions.
But the architecture of the iMedix platform, as detailed in their disclaimers, highlights the stark contradictions of modern digital healthcare.
Yeah, let's look at those disclaimers.
The site explicitly states it is an independent platform. It utilizes strong disclaimer language stating the content is for informational purposes only. It does not replace professional diagnosis.
And it explicitly asserts iMedix does not sell, dispense, or distribute medications.
Right.
So what does this all mean when you juxtapose that strict disclaimer directly against their advertising disclosure?
This is the crux of the issue.
The disclosure plainly states, iMedix may receive a commission if you purchase products through the pharmacy links on this page.
It's a direct financial incentive.
Think about the ecosystem here. The platform is hosting peer-reviewed clinical articles by professionals like Dr. Carlos Peña and Dr. Amrutha CD.
Real medical professional.
They are providing highly accurate data on CYP3A4 metabolic pathways and the severe risks of 80 milligram formulations. They explicitly classify the drug as not approved.
All of that is highly responsible.
Yet, they monetize the traffic by providing affiliate links to external entities that presumably distribute this exact unapproved medication.
It creates an ecosystem where objective medical information and commercial incentivization are inextricably linked.
It's a conflict of interest built into the architecture.
Exactly. And the platform effectively shifts the entirety of the health literacy burden onto the consumer.
The patient has to figure it out.
The patient arrives searching for trending tags like healthcare costs or alternative therapies. They are presented with a dizzying array of data.
The rigorous pharmacology, the severe contraindications.
The enthusiastic user validation, the regulatory warnings, and finally, the commercial point of access.
The buy button.
Right. The patient is required to synthesize the risk of an unverified supply chain against the financial relief of a gray market generic. And they must do all of this within an interface fundamentally designed to facilitate a transaction.
Wow. We have really dissected an immense amount of material today from the iMedix content engine.
We covered a lot of ground.
We analyzed the fundamental identity of Tadalafil as a PDE5 inhibitor and the regulatory friction surrounding its bioequivalence.
A whole not approved status.
Right. We explored the deep pharmacokinetic implications of a 17.5-hour half-life, which transitions therapy from a reactive event to a daily routine.
A major psychological shift for patients.
We examined the severe nonlinear toxicity risks of those high-dose gray market variants and the physiological cascade responsible for its extensive side effect profile.
The profound hypotension and the systemic vasodilation.
We navigated the metabolic bottlenecks of CYP3A4 inhibition and the clinical catch-22 for patients who are reliant on nitrates.
A really dangerous drug interactions.
And finally, we analyzed the sociological and commercial realities of the digital forum space, where these deeply emotional testimonials just collide right into affiliate marketing and legal disclaimers.
It is a comprehensive look at how modern pharmacology exists not just in a sterile laboratory setting, but in a highly complex, often contradictory global market.
It's messy.
It is. And as we conclude this deep dive, I think the iMedix source data presents a fundamental philosophical question regarding the nature of modern medicine.
Give us something to think about.
Well, we have spent an hour detailing the exact enzymatic pathways, the receptor saturations, and the plasma concentrations of a specific molecule. The clinical science is exact.
Undeniably.
Yet, this exact science is applied to a drug that exists entirely outside the framework of official regulatory approval.
The gray market.
Right. So if a generic manufacturer achieves true, verifiable bioequivalence, if the chemical structure is identical down to the molecular level, but they bypass the bureaucratic and financial hurdles of domestic FDA approval, at what point does a quote-unquote gray market compound cease being an illicit generic and simply become medicine?
That is a phenomenal question.
Furthermore, considering the intense focus on healthcare costs we saw in the forum data, how much of the global population's relief currently relies on this shadow economy of unapproved yet pharmacologically active generic medications, it challenges our basic assumptions about what constitutes legitimate healthcare.
That is a profound paradox to consider, and it perfectly encapsulates the complexities we uncover when we actually look past the surface of the data.
It's never as simple as the label implies.
Never. Thank you to everyone listening for bringing your focus and intellectual curiosity to the discussion today. We truly appreciate you joining us for this analysis, and we hope you leave with a much deeper, more nuanced understanding of the digital pharmaceutical landscape. Keep analyzing the data and keep diving deep.